Good morning, everyone. Welcome to the first TeleEcho network meeting for palliative care for 2019. I'm Naylor, I'm the Director of Nursing at Hospice Waikato, and I'm going to be facilitating the meeting this morning. I'm just going to start with a few notices. I'll just get them brought up on the screen. Change that one. So just for people who have not joined one of our meetings before, a few etiquette things to start off with. One of the important things we want to do is make sure that our case discussions are anonymised, so we will be doing our best and keeping an eye on everyone, but just please make sure you don't share any identifiable health information about the cases that we discuss. We are recording this session for educational purposes and it will probably be uploaded to our website. We have lots of organisations interested in what we're doing, so some other people may watch this. We will be controlling microphones just to keep people on mute so we don't have any unnecessary background noise, and we'll unmute you when you have a question or a comment. Just give us a wave if you do. I don't think there's anyone on phone, but if you are, don't put us on conference hold because everyone gets the music. And if you can just identify yourself when you speak so that everyone knows who's speaking and who you are. So we, just for the doctors out there, this echo session is approved CPD by the College of GPs. For other health professionals, including nurses, as long as we have your details, we'll send you a certificate of professional development hours as well. The agenda for today is, first there will be a short presentation which I'll be doing on just a brief introduction to Te Ara Whakapiri, the new last days of life care plan. We have two case presentations with Dr. Debbie Barham and Dr. Tom Reed, and any final remarks. So we'll be aiming to finish by 9 o'clock. Okay, so I'm going to go back to the video. What I'll do now is just get all of you who've joined us to introduce yourselves. So we'll go around my screen and I'll just ask you to introduce yourself and tell us where you're working or where you're calling in from. And we'll unmute you as we go around. So just start off with our first person is Ashley.
Good morning there. I'm Ashley Batard. I'm a nurse practitioner. I work for the Hauriki PHO and for Te Korowai, and I live in Whitianga on the Coromandel. I've got poor internet, so I'm sorry if I drop in and out.
You're looking good at the moment. Welcome.
Great, thanks.
Next we have, is it Tokoroa Hospital?
Yes, good morning. My name is Jan Smith. I'm a medical officer in Tokoroa Hospital. Unfortunately, I'm also working today in ED.
Okay, thanks for joining us. And David over in Whitianga as well. Oh, hang on, we just need sound, David.
Up.
Yep, okay, you're right.
Hey Ashley, you'll have to come around here next time because I've got regional internet. I'm a GP in Whitianga.
Next up we have Tom.
Hi everybody, I'm one of the palliative care specialists working both in Waikato Hospital and also a cross-site in Hospice, and so good morning and Happy New Year.
Lake Taupo Hospice, we can't see you but we can see that you're online. Anyone down there?
Maybe not.
Morena, Poke.
Oh.
Hello.
Hello.
Morena.
Can you guys just quickly do an introduction?
Hi, it's Karen here. I'm Barnett, the clinical at the hospice. Hi, everybody.
Hi.
I'm Judy Tunnicliffe here, one of the nurses, the community nurses. Gillian Cotman, clinical nurse educator.
Great, thank you. And then last we have Julia. She there too. No. Okay. She is there, but maybe not communicating with us. So thanks for introducing yourselves, everyone. We'll just do a quick introduction of people in the hub team here as well. I think we'll start with Viv.
Hi everyone, I'm just on the corner here, Vivian, Family Services Manager at Hospice.
Good morning, Madeline, Rural CNS.
Morning, Jackie Sliners, educator for Hospice.
Good morning, Debbie Barham, palliative medicine specialist in Waikato.
I've introduced myself.
Good morning, Andrea, Education Coordinator.
Good morning, my name's Gail Brooking, I'm the Spiritual Care Coordinator.
Hello, my name's Lana, I'm one of the advanced trainees here.
Morning, Billy in the IT.
Thanks very much, everybody. So I'll just move on now and do a quick teaching session. I know that some of you have already been introduced to Te Ara Whakapiri, but we just wanted to take this opportunity because it's being used across the Waikato now, and you'll slowly start to see it coming up in your area over the next few months. So I'll just bring up the presentation next. I think it's in
The other presentation.
Yeah, that one.
That's the one.
Great. So I'll do the presentation, then we'll have a little bit of time, and then if anyone has any questions or comments. Oh, thanks, I was going to add that in. So hopefully by the end of this short presentation, you will be able to discuss the development of Te Ara Whakapiri, describe the components of the Te Ara Whakapiri toolkit, and also be able to implement the Te Ara Whakapiri components into your clinical practice. Just to start off with a quick reminder and I guess a little bit on definition. So when we're talking about the last days of life, it's a part of the continuum of end-of-life care. And when we're talking about end of life, we're thinking about the last months, really, to weeks of life. Last days of life is specifically the last days to hours of someone's life, and that's when the last days of life care plans are designed to be used. So you don't want to start it weeks or months in advance. It's really designed for the last few days to make sure that we're meeting all the needs of the patient, their family whānau at that last period of their life. I guess most of you will know about the Liverpool care pathway, but just to give a brief background to how we got to where we are now, the Liverpool care pathway was developed in the 1990s in the UK, and the purpose of it was to take the principles of hospice palliative care out to non-palliative care specialists. In 2005, the Liverpool care pathway was introduced into New Zealand. There are a few minor modifications. The main one was the addition of cultural components. And some of you may recall that we had a national office that was coordinating the rollout of the LCP and was collecting national data on the LCP. And in actual fact, it was quite successfully being used across the country by hospices in hospitals and in a large number of aged care facilities. Unfortunately, in 2012-2013, there's quite a lot of media interest in the LCP in the UK, a lot of family members complaining that their relative had been put on the LCP and that they had then not got food or fluids, they had had treatment stopped, and they felt their care was not good. So there was an independent review which was published in July 2013, the Neuberger report, which found that while the livable care pathway was good, it was not being used correctly and people were not getting individualised care in the last days of life. It was being used as a tick box exercise, which is what the media had come up with. So in the UK, the livable care pathway was withdrawn, and the government there said that patients should have an individual plan of care developed for their last days of life. Consequently, in New Zealand, later that year, the Ministry of Health requested an independent investigation into the use of the LCP in New Zealand and what we might do differently. The 5 priorities from the review of the LCP were recognising the person may die and communicating that to the patient if possible and to their family. Sensitive communication and making sure that is documented. Involving people in decisions, and that's the person who's dying and their family whānau. Making sure that the needs of the family and loved ones are actively explored, respected and met, and also an individual plan of care was developed. And it addressed particularly specific things that were being talked about in the media and also highlighted in the review, that it needs to be holistic, it needs to include stuff about food and drink, needs to include symptom control, has to be agreed with the patient family, coordinated and delivered with compassion. So in New Zealand, the Last Days of Life Governance Group was brought together, initially under the Palliative Care Council, later transitioned to Palliative Care Advisory Group under the Ministry of Health. The governance group appointed a working group, and that group spent a few months reviewing the findings from the UK investigations and report. They did a stock take of what New Zealand services were doing at the time, because at this stage New Zealand had stopped using the LCP as well, following a directive from the ministry, and everyone was doing their own thing. Most areas had implemented a revised or adapted version of LCP version 11 or 12. They reviewed the literature, and they also did a survey of family and whānau of people who had a relative on the LCP or a Last Days of Life care plan. They produced a number of working papers and eventually produced a report that came out in 2017, Te Ara Whakapiri, Principles and Guidance for the Last Days of Life. Within that report there were 7 principles, fairly similar to the livable care pathway priorities. So care is person-centred, workforce is the right workforce, communication is clear and respectful, services are integrated, they move with the person, they're sustainable, services are nationally guided and supported, and there's appropriate access to resources and equipment. So Te Ara Whakapiri means the unifying path, and it's taking those key principles and initially the services across the country who had developed their own Last Days of Life care plan were asked to make sure that their care plans match the principles of Te Ara Whakapiri. One of the things that kind of happened at that time was recognition that across the country we were all doing things slightly differently. And people were moving between services or between areas, then the Last Days of Life care plans were not the same. So there's quite a strong push for the development of a national document. Initially, that wasn't going to be part of the working group's work plan, but because of the national call for a document that everyone was using, further work was done and the Te Ara Whakapiri toolkit was released. So the toolkit contains not just last days of life care plan, but some other documents that were found to be useful and were being used by services across the country as a part of their last days of life care plans. One of the most important things that came out of the review of the LCP was the fact that people were not being recognised as dying. So in the toolkit for New Zealand, we have a recognising the dying person flowchart, which is a new component. There is medical management planning, a new component, the care plan part, and then symptom management algorithms, also updated bereavement assessment tool, transfer of care checklist, and then some updated information brochures. So I'm just going to go through the Waikato version, because although we have a national document, we all like to do things our own way. We're a bit like that in New Zealand. So a lot of areas have done some very minor tweakings to the national document. Some of it's just to make it look a bit more pretty, fix up some formatting issues, and also in some cases to add a couple of things that aren't part of the national document. So in the Waikato, we have 3 different versions of the care plan. They're very similar, but just some minor differences depending on where the patient is. So there's an in-hospital version, an inpatient and residential care version, which we are using in our inpatient unit here at Hospice, and then a care at home version. So as I go through the document, I'll point out some of the differences. So the first thing you'll see in the toolkit is a recognising the dying person flowchart, and this is there to guide health professionals in recognising when they should be implementing Te Ara Whakapiri, and it's a multidisciplinary discussion. First, some medical management planning general principles, again, just to guide health professionals on when to start Te Ara Whakapiri, some of the principles around good care at the end of life, and also around reviewing medications, quite an important part of the care plan, but also one of the key things that was found in the review of the LCP, that medications were just being stopped or not being reviewed properly, preemptive prescribing wasn't being done. The first part of the actual care plan is a baseline assessment, and this covers all components of the patient's well-being. So we've linked it to Te Whare Tapawha, a Māori health model, looking at the physical, psychological, whānau and spiritual health of the patient and their family. In the document, this is what it looks like. And the purpose of doing the baseline assessment is to identify areas that you need to address to make sure the person's last days of life care is going to be well managed and that their family whānau are going to be supported. Once you've done your baseline assessment, developed an individualised care plan, it's important that there is ongoing assessment of the patient to make sure that their needs are being met. This is where the different care plans have some slight differences. So for an inpatient or person in residential care, the recommendation is that they are assessed at least once a shift. But in the community, because we're not seeing patients that often, they're just assessed once a day. So the frequency of assessments is slightly different. Also in the community one, or the care at home, there is the ability for family members to do the ongoing assessment. So the wording of the questions in the ongoing assessment, which is this next slide, is slightly different. So it's a little bit more, the language is simpler so that a family member can read the question and can assess the patient themselves. The way that the ongoing assessment works is it has a coding system, the ACE coding. Again, slightly different wording for the home care one, but the A is for achieved or all good, so there's nothing that needs to be done. C is that there is a change and something needs to be changed in the care plan. And E is extra help, or for the inpatient one, it's escalate. So you're going to another health professional for advice on what to do with the patient's symptom or problem because it's not being managed properly. If there is a C or an E recorded in the ongoing care, then something should be documented in the patient's notes and their care plan may need to be updated. There's a section on care after death. Some of these questions may be answered before the person actually dies, but it's a checklist to make sure that things are done appropriately once the person has died and that there's appropriate support put in place for the family. The toolkit has updated symptom management guidelines. We've looked at them in our Waikato one and made sure that they match what we do across our area. Maybe slight differences in other parts of the country, but probably not a great deal. And these symptom algorithms cover pain, dyspnea, respiratory tract secretions, agitation, delirium, and nausea and vomiting. What is new with this section is rather than just having the flow chart, which is on the right-hand side of the screen, each of the symptoms also has another page that has a definition, has some information about assessment, and also has information on non-pharmacological approaches to management. So rather than just going straight for drugs, there are some other options that can be used, and particularly may be used by non-medical staff as well. So each of the symptoms has both of those components. The pain symptom management one has two flow charts, a standard one and one for renal impairment. Another of the new additions is a complicated bereavement risk assessment tool. So this is to assess family whānau and carers to see if they're at risk for complex bereavement once the person has died. Fairly easy to complete. It does give you a rating score, and for someone who's at moderate to high risk, there is a recommendation of additional support and perhaps referral to a specialist bereavement service. For people who are being transferred from hospital or from hospice inpatient unit to home or to an aged care facility, there is often some challenges because it can happen quite quickly. The person's been transferred home for last days of life care, and there are a lot of things that need to be put in place, and if they're not put in place, their transfer home can be not that great. So the purpose of the checklist for transfer of care is to make sure that those key things are done. This is just a half of the checklist up there at the moment, and this part of the toolkit across the country has been modified by most services to match their local procedures. So there is one designed for a hospital transfer home. We have a couple of different ones here at Hospice for transferring home or to an aged care facility. And then the last thing is just some updated leaflets to match the new Te Ara Whakapiri documentation. So there's information leaflet for family members on what Te Ara Whakapiri is, slightly updated version on what to expect when someone is dying, and another one on what to expect when someone dies at home. And that primarily relates to things like what to do when the person dies, contacting funeral services and things like that. So all of these documents are available on the Hospice Waikato website under Education and Resources or Health Professional tab. There's a clinical resources page now that has all the Te Ara Whakapiri documents on there. In hospital, they are on the intranet or available from the print room. So all the documents have codes on them. And that's the end of the presentation. we'll just go back to video, and got about 5 minutes for questions or comments if anyone has any. Just give us a wave and we'll unmute you. We're not going to be able to see Lake Taupo Hospice.
Use the chat function.
Maybe just unmute. Anyone at Lake Taupo Hospice have any questions or comments? No. Anyone who's online use the Last Days of Life care plan yet, or the toolkit? No? Okay, so just so you know what is going to be happening with the toolkit or the Te Ara Whakapiri in the Waikato, we've done some education sessions already at Tamanui and Tokoroa and some of the aged care facilities. It is going to be rolled out as a part of a new initiative into aged care facilities as a part of a palliative care approach pilot. So Last Days of Life care plans are part of that. And we'll be getting to district nursing services. We have met with most of them. We haven't yet met with the ones over in Thames Coromandel, so we'll be doing that in the near future. And we'll also be trying to get out to GPs as much as possible to tell them about it, tell them where they can find it, and support them to use it. So hopefully you'll start seeing it more as the year goes by. Okay. No questions and comments, then we'll move on to the next part, which is our case presentations. So our first case is going to be presented by Dr. Debbie Barham, who's sitting next to me. So for people who've just joined us for the first time, the way that we do the case presentations is the presenter will run through the case, we'll bring it up on the screen. You should have been sent it as well. And then once the case has been presented, I will ask the spoke sites, which is you guys who've joined in, if you have any questions or anything you'd like clarified about the case. I'll then ask the hub team if they have any questions, and then we'll move to recommendations. So everyone will have a chance to provide recommendations on the management of the patient. So I'll hand over to Debbie and she can present our first case, and we'll just bring it up on the screen.
So good morning, everyone. Thank you, Wayne. And this kind of dovetails nicely into your Te Ara Whakapiri because it is a case of end-of-life care. This is a historical case now, but I thought it raises some good discussion points or teaching opportunities. So I'm going to talk to you about a gentleman of 71. And the two key questions that I really wanted to focus on in this case were, number one, around the medical aspects and acknowledging that there was a large degree of uncertainty. And so how do we appropriately approach that from a medication in particular perspective? The second point being, in the wider context, how do we support this person's whānau? This is a not uncommon situation where things are unexpected and they're suddenly found to be in a caregiving situation with little warning and little preparation. So those are the two key questions to be thinking about. I'll introduce you to the gentleman that I met. This is a 71-year-old man whose diagnosis was uncertain. He likely had an undiagnosed GI malignancy, and he certainly had a new acute on chronic renal failure. By way of context, this is a 71-year-old Māori gentleman living in an urban area in a Housing New Zealand home, lived with his wife, who herself had significant health concerns, and prior to this episode, her health was of more concern to the whānau than his. They did have a close supportive whānau, none of whom were living in the home with them, but many of whom lived in the same town. The context of this presentation, I was asked to see this gentleman the day after he had self-discharged from Waikato Hospital. We had been in the high dependency unit. He had decided against medical advice to discharge home, as he felt that his preference was to be at home for supportive care. He'd been admitted to hospital 3 days before that after he'd had a significant fall at home with associated injuries, a lot of facial fractures, and he had ongoing GI bleeding, quite significant volume. While he was in hospital over those 3 days, he had developed acute renal failure, and prior to discharge was anuric, not making any urine at all. He had ongoing large volume PR bleeding, had at various times been fluid overloaded and cardiac failure, although this had been treated. He did have an upper GI scope done, which really was non-contributory. Just by context, when he went home, his haemoglobin the day of discharge was sitting around 82, though had been significantly lower during his admission. This gentleman had a number of medical comorbidities. You can see listed there. I won't read them all out, but of probably the key things to keep in mind, he had previously been on anticoagulation at the time of his GI bleeding. For atrial fibrillation, he had a history of significant heart disease and vascular disease, and he is on insulin because he has type 2 diabetes. The diabetes obviously had caused a degree of renal impairment, but he now found himself in acute renal failure. Physical aspects of his presentation at the time. He had ongoing PR bleeding, so after discharging home, he had at least 3 episodes of large volume, bright red, fresh blood PR. Very difficult to know how much that was, but we could see evidence of blood all down the hallway at home, likely reflecting a lower GI source. So while he had been scoped from the top, he hadn't had any investigations from lower down, nor had he had any imaging. That would have been helpful to know what the cause of that was. Importantly, he had stopped his warfarin, so was no longer on his anticoagulation. He is significantly fatigued. At the time when I met him, he was alert, he was able to talk to us, but fell asleep numerous times during the consultation. He was a little breathless, not significantly fluid overloaded, and I felt that the breathlessness probably related more to his anemia and the overall situation than to cardiac failure at the time. Was requiring, when we met him, at least 2 people to assist him to the bathroom. He was still very adamant that he could get there, but that was not shared quite so convincingly by his family. He had evidence of his obvious injuries, was extensively bruised, and was uncomfortable because of that. From a diabetes perspective, he was still eating. He had been eating since he was discharged home. Hadn't actually been testing his blood sugars, didn't have any record of what they had been in hospital that I had available. He was still having his Lantus given by his family. And although he had not passed any urine while in hospital, his family members felt perhaps he had passed some urine overnight, but this is very difficult to gauge the accuracy of. His medications, he had no idea what he took. His family had no idea what he took, but we did find a blister pack in the kitchen, and the medications that were in that pack were listed there. They had given those medications in the morning, so it's unclear how many of them he was able to swallow, but some of them came back up. They had given his insulin since he'd returned home. From a psychological point of view, some of the history I shared before. His wife was with him at the time of the consult. She was very pleasant, but clearly physically unwell herself and really unable to answer any questions with any reliability, so a degree of cognitive impairment. The daughter, who lived nearby, was working at the time as a teacher. It happened to be school holidays, so fortuitous, and that she was able to be in the house the day that he self-discharged. But we were looking at the new term commencing about 3 days later, and so she was faced with, crikey, what am I going to do? Can I go back to work in 3 days, and how am I going to look after both parents in this situation? Granddaughters also lived locally. Both of them were working, but they were also expected to play a caregiving role in this situation. The whānau nominated this gentleman's son really as the primary person for us to be liaising with. However, he was in another country and not due to arrive for 2 or 3 days at that stage. So at that point, he really had only just had a rushed phone call, please come home. Didn't really understand any of the context of what was going on, and we were unable to speak with him. I had not met this gentleman previously, and we didn't really have the opportunity to have a big discussion about his past history in terms of background. The home situation, they were in a single-storey Housing New Zealand accommodation, very small unit, and the bathroom was accessed down a very narrow hallway. Obviously, this was really difficult for the family when he was needing 2 or 3 people to mobilise. Was in quite a state the day that we arrived, with blood all over the carpet and down the corridor. From a spiritual perspective, identified strongly with his Māori worldview, and his whānau were key for him. This was perhaps the biggest driver for him wanting to self-discharge from the hospital, acknowledging that, you know, a tertiary hospital situation is not how he wants to do life. And perhaps from a spiritual perspective, he had appreciated where he was in the context of his illness, perhaps even more than the medical teams were willing to admit at the time. So his preference really was in conflict with what some of the hospital specialists were advising, which raised the ethical concerns that I can see there. Some of the issue at the time was that he had self-discharged. He had recognised and he had a preference for what he wanted to do, but he hadn't communicated that with his whānau at the time. So essentially they got the phone call, come and pick me up, you're looking after me, with no discussion and no warning or time to prepare for that. So the daughter, who was this key primary carer at the time, had said to us in another room, you know, he could have just given me at least half a day. I could have, you know, I needed to make some preparations for this. I just got this phone call and had to drop everything. So there was a bit of conflict as a result of that. They, on the other hand, did really want to respect this elder in their family who they wanted to look after. They wanted to respect his wishes and care for him in what was likely to be an end-of-life situation. So we're really struggling with that conflict, I think, wanting to respect their own needs, but really wanting to honour their father and grandfather. And the difficulty that the person who the patient himself had nominated was actually not even in the country and not part of this picture at all at this point. From a communication perspective, when we met, he was able to speak with us, really short sentences and able to answer direct questions, but we weren't able to have a really in-depth conversation with him because he was so tired. He did have some hearing impairment, which made for some interesting and comical conversations at times too. He clearly did appear to understand the seriousness of what was going on. He didn't seem concerned about some of the uncertainties. He didn't have a need to know the answers. He didn't particularly want to have any more investigations. He didn't feel the need to know where the cause of the bleeding was coming from, or even what might happen. He just wanted to know how we were practically going to do this. The partnership side of things, it was nice to see that both the patient and his family caregivers were in agreement about his wish not to be back in hospital and not to have any more treatment. So that was one degree of conflict we could avoid. They were open about asking about a DNR order. That was, you know, their terminology. Can we talk about DNR? We want to make sure we don't resuscitate. So we had a really good conversation about that. Really opened the door to, okay, resuscitation is part of the picture, but there's a bigger discussion about goals of care and what does he want? What are the preferences? What are the things that we should place importance on? So it was really nice to be able to have that conversation, more so with his daughter and granddaughter than with the patient himself. He was happy for us to talk with them. he expressed clearly that his preference was to stay at home, that he didn't want to be back at hospital, but he did say at one point, look, if my family can't cope or if things can't be managed at home, I'm not going to be a stubborn old beep, and I will let you take me back to hospital. So he was a lovely gentleman who did really understand. The GP who knew this patient, this always happens out of hours, and hadn't yet had an opportunity to meet this person. He was due to arrive in the next 24 hours and almost certainly was not up to date with what had happened from a medical perspective. Because it was a discharge against medical advice, there was not a discharge summary. There was no communication with the outside world other than us, because we happened to have one of our team had met this gentleman in hospital, so that was lucky that we could refer to our own service and get on board fairly acutely. So that's the presentation. Be nice to hear. Does anyone have any questions or anything you'd like me to clarify about that?
Go back to video, please.
David.
Yep. So we'll go to David first off, who's waving.
Hello. Hey, thanks, Debbie. That sounds like a really exciting case, so to speak. So do I understand who actually has the power of attorney, do you think? Would it be the son or would it be the daughter?
Well, there was no formal power of attorney. No,
Yeah.
There was nothing from a legal perspective. So we couldn't pursue that. There wasn't time, and he didn't have the capacity at that point to really pursue those conversations. Yeah. So the good thing in this situation is that the family in the room at the time and the patient seemed to be in agreement, so we didn't need to have that conversation. There wasn't conflict about what way we were going to do things. But I acknowledge that's not always the situation.
Oh, yeah. Yeah.
So if it was a different case, we would probably have had to speak with the daughter who was in the room at the time.
Yeah, and you essentially did an advanced care plan, but by your description. Hey, it just underlines the importance of communication between medical people, doesn't it? Well done, Debs. Thank you very much.
Yeah. I think, and that's one of the biggest issues was around just trying to decide where do we go from here and who do we need to be communicating with.
Yeah.
Tom?
Yeah, Tom.
I think this case, I remember it well because I was the gentleman asked to come and see him just coming into the evening, a typical end of the day referral, after this guy had been seen by about 3 acute teams in the high dependency unit, all getting increasingly upset that this guy had expressed his very clear wish, despite having major hemorrhage, wanting to go home. And everybody, as we know in the acute sphere, gets increasingly uncomfortable when patients seem to be making decisions that don't fit with the more conventional biomedical norm. And yet this guy had I was so impressed by him when I came and saw him at about, I think it was 5:30 in the evening in the high dependency unit. He had patiently waited for me to come out of respect, even though he'd already had arguments with his daughter, I believe, that he wanted to go home. And there was no question of the hierarchy here. They were going to honour his wishes. It was powerful stuff. And although we weren't able to produce formal documentation, it was one of those occasions where some direct communication from a hospital palliative care team was helpful to cross that transition into the community. And Debbie completely picked up with the team in the community, having had the initial conversations and plan put in place in the hospital. So I don't know whether that's useful background as well, but it was one of those cases to reflect on from managing our levels of comfort as practitioners when a patient is expressing the wish to do something that may not meet our conventional wisdom or what we think with our Western view of medicine is the right thing.
I think for me that's exactly right, Tom. The whole against medical advice thing, he discharged against medical advice. Well, we were the medics listening to this man in the first place.
we did manage to make sure he got prescriptions and everything when he left. There was no question that he wasn't going to get all of those. All of that was done.
But only because Palcare had been involved. You know, for prior to that, there were a number of professionals who had the opportunity to ask this man what mattered to him and how we could honour that. And I think it just raises for me one of the ethical issues with, you know, who says medical advice is right? Our medical advice should always be tailored to what is right for the patient, for the individual in the situation. And that was the gap before your team were able to be involved, I think. Anything else to clarify? Questions from anyone else?
Just want to check with Taupo. We've unmuted you guys. Like Taupo, you got any questions or clarifications you wanted to ask Debbie? Okay. Any questions from you, Ashley? Sorry, we're just yeah, go ahead.
No, I guess I'm just thankful that the case happened in an urban setting, because I can imagine the difficulty if this man was living very rurally and you weren't able to step in at that point. It could have been a very, very different outcome for the family.
Yeah. Absolutely, and part of the reason that I'm really wanting to present the case today to discuss how would we have managed this rurally. So I'd be really keen to hear your guys' thoughts about how this could have played out differently and what we could have done collaboratively to make this work if we weren't able to be on the ground like this.
Yeah, great.
Okay, we might move then to people's thoughts and recommendations on this case, and in particular around the questions that Debbie had posed around how to rationalise his medications, particularly in relation to his renal failure and uncertainty about what his diagnosis is, and how best to support the whānau who suddenly found themselves in a caring role that they weren't entirely prepared for, and with potentially not having a key spokesperson easily available. So I'll go out to the spoke sites again. If you have any thoughts, ideas or recommendations, give us a wave and we will unmute you. I would be particularly, as Debbie said, interested in hearing from the rural folks around how you might look at this if the person was going home to Tokoroa or Whitianga or somewhere far up the Coromandel. Yep, David.
I'm sure this is no different to what anyone else would do, but in those circumstances, I would make sure that the whānau had my telephone number, my own cell phone number, as well as knowing who the doctor on call was. In other words, if I wasn't on call, that they knew there was support somewhere. And I'd ask them very nicely not to phone me at 3 o'clock in the morning unless they had to, of course. But these guys wouldn't phone me at 3. You know, they're respectful people. It was interesting what Ashley said about if this had come out rurally in those circumstances, because in my probably limited experience, but there is a lot of whānau support for the Māori people living in our area, and I like to think the family would get a lot of support from the Māori and other people living around here. It's not always going to happen, I appreciate, Debbie, but it's interesting. Yeah, that's me.
I guess by way of feedback to that, David, I agree with you that while we sometimes think it would be harder in rural areas, actually the rural areas are the ones that step up and do it really well. There are non-trained professionals, you know, just volunteers in the community who make things happen. While we might not have had the professional services available that we have here, as sure as eggs, the local community would have stepped in and this would have been sorted out there are networks established, people know who they're going to phone and who's going to do things. I found in our experience it's actually harder the closer they are to the tertiary hospital.
Yeah. Yes.
Which it seems a little strange, but that's the way.
Yeah, no, I agree.
So, kudos,
totally agree.
kudos to the rural communities who do a great job.
Does anybody have any thoughts on the medications? It's on quite a substantial list of meds and whether or not they're all still appropriate given his current situation. Tom must have.
I can't remember exactly what we sent this gentleman out on, but I think with his level of sort of sleepiness and so on, and the great potential, I just do remember that he was having huge PR bleeds still. I felt that the potential for him to die quite quickly was high, and so I had a low threshold to go to subcutaneous medications that would be more family, easier for the family to administer. And obviously I would use an opioid both in the... Pain was a huge issue for this man, I remember, but it's certainly from the point of view of breathlessness, opioids would still have their place, and but we would probably aim to use one which was renally friendly. So I can't remember exactly what, I imagine fentanyl was used, if I remember rightly. Debbie, maybe you can help?
Yeah, well, Ashley had a comment, so maybe we'll hear from Ashley first, and then I'll tell you what we did. Yeah.
And I was just going to say, I think that's a fabulous idea, Tom, because the other thing that does with switching to the subcut medication, removing the orals, is that takes that away from the family, because they've been put in this situation to manage, you know, very suddenly. And so if we kind of take over that medication management largely, that's going to lighten the load for the family as well.
Yeah, so I think both of those points are really key. Number one, nobody in the house really knew what he was meant to be on at all. So it was an opportunity to sit down and just start afresh, really. And they did find the blister pack that they'd been using, and I basically just said, let's just scrap all of it. What are the key symptoms that he has at the moment, and what is the best way for us to administer medications? Really, he's lost his oral route with that amount of PR bleeding. It's not going to absorb anything. I don't know what's going on in his gut. So it really is a bit pointless to pursue asking him to swallow tablets that we don't even know are going to work. So yes, essentially we did anticipatory subcut prescribing with some advice around symptom management, very consistent with Te Ara Whakapiri actually, so that fits nicely today. And I don't know that he actually really required much at all. Fentanyl was the opioid of choice, acknowledging that, you know, our hospice nurses can be there for 1 hour a day. The GP was going to be visiting for maybe another hour a day, but 22 hours a day, the family are going to have to administer these medications. So very quick upskilling for the family about what to give and how and when. So written instructions, really important. Not just telling them, because we don't know who's going to be in the house at any given moment of the day, and trying to not use medical terminology. So literally take a picture of the vial of the medication and leave it with written instructions. This is the one that you use for breathlessness, or this is the one that you use if he's feeling nauseated. The one, I guess, medical question on the day was, do we try and give him anything to settle the bleeding? Acknowledging that it's not going to change the overall outcome, and it may not make a difference to the time frame, but the amount of blood in the house was pretty scary to look at if you're a family member walking in the door. So was there a role for something like tranexamic acid for whatever worth it was going to be? So given his renal failure, the dosing of tranexamic acid at the time is a single dose in a day. And so we did opt to give that, which I think did reduce his bleeding a little bit. And, you know, the more that he bled, the less he was going to bleed. So it did settle things down. That was the sort of one question I had on the day, do we pursue that or not? But had a good discussion about it. And then communicating that with the GP who was about to arrive in the house. So, you know, I didn't want to step on their toes. but we needed to make those decisions then and there and have a clear plan. So it allowed the GP not to have to focus on that, to be able to focus on perhaps the things that are far more important than medications.
I just want to check if anyone in our hub team have any recommendations or suggestions for this case as well.
I guess, Family Services Manager, I guess I wonder how long after that then did he pass away? Yeah. Which of course we wouldn't have known at the time. And it's just that rub between, is this really happening pretty quickly, and who's the best person to give that emotional support and reassure the family and help them process, albeit briefly, this kind of quite a horror really with a lot of blood. It would have been pretty scary. You don't know what people's backgrounds are, etc., versus how soon might a social worker get out there, maybe a counsellor, but I'm thinking a social worker to just hear a bit, be reassuring and say, look, if we do have a little bit more time, there's one or two options should you feel the need, and your dad might buy into the local rest home, whatever. And I'm quite caught about whether any of that would have been appropriate. Yeah.
And
Too much. Yeah.
I think one of the learning points, and perhaps we've already touched on it, was that there's a temptation to think, what specialist services can we put in here? We could have a counsellor, we could have a social worker, there's so much uncertainty that you really have to go back to the family and say, what do you need now in this moment and on this day? What is going to make a difference to you? And that question just needs to keep being asked, because that will look different tomorrow. The answer in this case was that he died within 2 or 3 days, so it was a short time frame. But had we been faced 3 days down the track with, okay, the daughter's got to go back to work or make a plan for not going back to work, then who would we have needed to put in place?
And that would be at that point.
Yes, and I think perhaps in a rural community, the answers would have come from the community. It would have been the neighbour next door, and it would have been, the grocer, and it would have been, those people would have stepped in at the time. So a really good learning point for urban communities that we don't do this well, and we don't get those unskilled networks in place quickly. We tend to go straight to, what specialist can I put in there? So there's a rub both ways there.
And there's another point for me is, I would want to know from the family what might they want to do about the blood. I feel quite concerned for them, not knowing what that means for them.
And very practical stuff.
Really practical. What would they need? Would they need help with matting? Are we just going to cover that over? It's pretty terrible to keep living for several days, because there might not have been a lot of room to walk around. It just seems really quite a lot of horror, I think. They're already traumatised from this all happening so fast and not being able to put their own lives in a planned way. So for me, if it was me, I'd be willing to just say, let's take 2 or 3 days and get something we can walk on. I don't know what it would be, but I think it needs talking about.
I mean, I think the key thing really to how to support people is to communicate with them. You can't make assumptions, you can't make judgments, we can't tell them what we think is the most important. They have to tell us, but they'll only tell us if we ask and if we listen to the answer.
And we'll only ask if we are in tune with our own personal response, not telling them what our response is, but using that to inquire and empathise with what they might be feeling. So we don't even get to the questions unless we're in tune with our response to what's happening. I think that's that personal, professional interface that's absolutely pivotal at times like that.
Okay, so we need to move to the next case. I'm just wondering, Debbie, if that was enough answers for your questions.
I think this was maybe slightly different to how we've done it, and that the case has passed. It's more a learning opportunity. So we don't necessarily need recommendations, but thank you for the discussion and the points that it brought out.
Great. Okay, so we'll move on to our second case now.
Hi. Just before you move on, is it okay if we just say something?
Please do.
Of course.
What time? You asked how you would, what would be beneficial when you are transferring someone into the community, just as this gentleman. A real key thing is to ensure that we have the medication, because our patients who are 80 k's away from a small town and the pharmacy might be 20 minutes away and doesn't open on the weekend, we can't get the medication. So ensuring that the medication script is filled by the hospital before they're discharged, so that we've got everything there, is a really, really important thing. We manage a lot of patients rurally, and as others have said, the community really supports their social and spiritual and emotional needs quite significantly compared to your high density areas. But a key thing is having those medications, not just sending them home with the script, and all the anticipated medications.
Yeah.
Yeah.
Great, thanks, Janine.
Thank you, that's absolutely key.
Just to quickly add there, from a hospital team point of view, we are really conscious of that, so thank you so much for identifying it. We're also aware that some of the medications we often use freely in hospital are not available in the rural pharmacies. So we actually have a hospital pharmacy, certainly in the Waikato hospital now, and we try to get, when we were using like subcutaneous oxycodone particularly, it doesn't seem to be available in a lot of the more peripheral pharmacies, and so we actually ask the families to pick up the prescriptions from the hospital pharmacy before they go home. Cool.
And I guess the other question is, whereabouts in this case study was it clear or review that the conversation was had that this gentleman was actually dying?
Yes, when we visited him, that I think perhaps, Tom, you'd had that conversation in hospital before he discharged. The gentleman himself identified it very early on in the piece, and then our hospital team were able to have a conversation. When I visited with our nurses, we had the same conversation, and clearly the family had discussed it between themselves before we'd even arrived. So it was explicitly mentioned. There was an acknowledgement that things were uncertain, but that the one certain thing was that time was very short, that he was dying. We just didn't know the absolutes that went with that.
Yeah, and so yeah, your clear reason why I wanted to go home straight away.
Yeah, yeah.
Great. So
Awesome.
we do need to move on to Tom. So we'll just bring up your case, Tom, and you could present that. That would be great. And four. Next one over. Great, and unmute.
That's all right. So we get a bit more conversation and less talking. Sorry, can you hear me?
Yep.
Both of the cases are historical today. So this is another historical case that I was involved in, and Debbie. I will give you the questions for the case presentation after I quickly flick through the story. So a 74-year-old male with a recurrent urothelial carcinoma, who'd been through a long journey of surgeries, as you can see. Left with no bladder, cystectomy, passing urine through a ileal conduit, and metastasis elsewhere in the body as well. Also significant comorbidities, as you can say, including interstitial lung disease, bit of COPD, and depression and anxiety. And a really complex background psychosocial scenario. And this was a gentleman from the north of England who had emigrated from the UK very much for a golden retirement, and sadly had recurrence diagnosed pretty much the minute he arrived. And so all of the sort of baggage that went with that about missing out on the retirement that he wanted, dealing with anxiety around his symptoms, and also his wife's carer fatigue and anxiety as well, and also previous memories and bad experiences, almost dying from urosepsis in an ambulance, leaving him terrified of an ambulance ride anywhere, and also terrified of hospital. So I think if we go through sort of the more interesting discussion points, ethical issues, well, there was the maintaining the confidence and privacy of this patient, because his main area of pain was associated with the base of his penis and his perineum. I mean, it's not easy things to talk about for a guy who's trying to maintain his sort of pride, but he had a horrible sort of 6 to 7 centimeter cystic recurrent mass at the base of the penis, involving the cavernosum, the vulva cavernosum, and also the perineum. And so even talking around it was difficult. Supporting his wife, who was really struggling, getting up 6 times a night to empty his ileal conduit bag, and so sleep deprived, and all of her anxiety. And so supporting her whilst also supporting the patient. And really, when we were starting to feel that we were going to need to go down the line of more interventional approaches, which you may well suggest, you know, having to thoroughly justify any thought of even a patient transfer anywhere, be it even to our inpatient unit for pain stabilization, the hospital for an intervention, or even just an ambulance ride, need to be very clear in our minds as to the benefits the patient's going to get versus the fear that he has to experience from previous experiences in ambulances. And he wished to be at home ultimately, and yet was struggling very much with a really complex, horrible, predominantly neuropathic pain in a very personal area of his body. So I think you have my summary there, which I imagine you've had a read of. I know that time is short, so why don't we move into a discussion? And I just thought 2 discussion points might be, what is the origin of this pain? I'm a physician, I always try to think where the pain's coming from, and I'm trying to focus how I might treat it, but at the same time, I was acutely aware of the multi-dimensional aspects of pain for this gentleman, in that clearly there was a neuropathic pain component, but there was also huge psychosocial overlays which were contributing towards his pain, and how we might best manage that too. Over to you.
So I'll just go out to the spoke sites then. Anyone have any questions, clarifications for Tom about this case? And how about anyone here in the hub room? Do you have any questions, clarifications for Tom?
Tom, was the tumour area dressed? Was it obvious and visible and being dressed daily by district nurses, or is it something the wife would have been viewing every time she changed the bag, emptied the ileal conduit?
Actually, the tumour area, which was the source of pain, hadn't broken through. It was internal. It was at the base of the penis and the perineum, but it was deep to the superficial tissues. So it was deeper structures, and I think that was an interesting line of thought as to how we might manage that pain in a more interventional way. And if more questions aren't coming, I can lead you on through our thought process and what we did do.
I just wondered, Tom, if the continence service was involved around his ileal conduit and managing that in a way that was less disruptive.
The ileal conduit management was pretty good, actually. I mean, the wife was very, I mean, it was managed through a colostomy type bag and into a larger urine bag. I think her concern, his output was quite high, and so she was up multiple times overnight. He'd had lots of UTIs, as you often do with ileal conduits, and nearly died from them, and actually finally passed away from one. But I think her management of that was pretty good. It was just very draining on her, because she was trying to keep the bag empty so that there was no possibility of reflux, you see.
Okay.
But I don't believe that the formal continence service was involved.
Okay. Anyone else have any questions?
Just wondered what the allied support for this person was in their community, having immigrated, living rurally. Did they have many support networks around the more social aspect?
Yeah, I mean, he had children out here, and I think that was one of the reasons that he wanted to come and retire here. He lived in a nice rural town where I'm sure they had good friends and so on. They had a fantastic district nursing team, and super GP support as well. You know, really involved GP. He was just a very complex case, unfortunately, and so one of those situations where you try to tailor his care to his goals of care and his wishes, but sometimes, certainly at the beginning of this case, we felt that we might not be able to manage him with more conventional approaches.
Tom, can you let us know what medications he was on for pain, or what had been tried?
Yeah. So from the point of view of pain, he'd had a admission in December of 2015. I think I wrote that down, where he'd got radiation to this mass in the perineum, and it had actually been beneficial from a pain perspective. So he'd had an interventional approach, and then the decision had been made for best supportive care from there. So he was being managed with oxycodone, and that was being relatively effective, but it was very much instant pain. Any movement was exquisitely painful, you know, lancinating pain in an area that you don't want lancinating pain, to the point that he would be sobbing. It was really distressing for all when the episodes of pain came on. Oxycodone had been effective, but it was becoming less effective over about a 2-week period when I did a home visit initially. And then to move the conversation on, my next step, because of the nature of the pain, was to move to methadone.
So I might just go to the spokes then and see if anyone has some thoughts around the cause of this man's significant pain and any other options to treat it, and around managing the psychosocial components related to, I guess, his significant change in what his life had aimed to be. And just from Tom's notes around his being a long way from his home in the UK, and not probably going to be able to get back there, etc. So, anyone in the spoke sites, David? Yeah, David has.
Well, I suppose depression. I haven't got your list of what drugs you got him on in front of me, Tom. And I'm not sure what other people would think of the idea of putting him on antidepressants. I mean, the thing is, if you use something like venlafaxine, they do have a pain relieving function as well. And I think I did see you got him on gabapentin. I was wondering if that was any use for him at all.
He was on citalopram 20 milligrams for depression. Okay. And yes, the gabapentin, I believe, had been relatively effective. Remembering now that we have pregabalin, which personally, I don't know whether you guys are having as good an experience with it, but I'm having a great experience with
yes, very much.
And with the added benefit that it can sometimes even tweak mood too. So certainly the gabapentin was a good idea, was not fully optimized. He was on citalopram for depression. One of the complexities around his anxiety, however, was that he seemed to have a very sensitive, seemed to be extremely sensitive to benzodiazepines, and really that there was clearly a need to have that in our armory, but to negotiate him to retrial those, both him and his wife, was very difficult because they felt that they were very dangerous to him and were off the table. But I think things were at a point where we needed something that we could use more acutely for anxiety and panic. But venlafaxine, yes, absolutely.
What was, I don't know, sort of like quetiapine or anything like that?
I suppose, yes, that would have been another option. Yeah. I'm not sure whether people wanted me to continue the story and tell you what went on from there, but please let the hubs finish questions and things first, perhaps.
Yeah, any other thoughts from the spoke sites? No? Like Taupo, any thoughts down there?
For his wife, we probably, and for him, we probably referred to our family support team, so that there was some one-on-one and some couple support from our counsellor. And overnight, we probably pop in a night carer so that his wife could have a couple of nights sleep, and the night carer would change the bag, so to support the wider family that way. But it'll be interesting to see what pain medications you actually utilised.
Any other thoughts from our hub team?
I'm sure Tom's going to speak to it, but I think your question sort of leads to it. Where is the pain coming from? And the fact that it is so localised, do we have localised options to manage this? That so far the management has all been systemic medications. What else is in, what else could we be thinking a little bit outside the square? And I'm sure that's where you're going to lead us, Tom.
So where do we go? Well, I think the complexities of this case were further interventional approaches were going to be contrary to his wishes to be at home, I think is the main thing. I started small doses of methadone, 2.5 milligrams, 2.5 milligrams BD. I think he even ended up on as an adjuvant to the prominent opioid he was on. And actually, with great, it seemed to work well. However, I wonder in retrospect whether the improvement in his pain came about through a respite admission in our inpatient unit, which we negotiated as a halfway house to going to hospital. It allowed us to support his wife and give her some time. It allowed us to tinker with his medications and trial some benzodiazepines in a controlled environment where he felt a bit more safe and supported. And really, we didn't make huge changes to his medications, and yet there was a, reading back through the notes, the value of the retrospectoscope, there was a significant improvement in his pain. If there hadn't been, our next step would have been a pudendal nerve block, which we investigated through the inpatient pain service in Waikato Hospital. They haven't done one in a male previously, but obviously more common procedure done around childbirth in ladies, but they were happy to do it if necessary. We didn't pursue it because things seemed to improve and his wishes were to get back home on the regime that we had him on. I wonder whether a lot of the improvement came from the respite admission and producing more cares at home and getting him back home. He finally passed away from a recurrent UTI, which he chose not to treat in a short period of time. Another alternative, which would have been even more interventional, would have been an intrathecal, which we don't really use very much in our rural location, but they do have a service up in Auckland. But that had the potential issues of tying him to a bed in a hospital or certainly in a higher level care establishment, which wasn't his wish. So that was the general thought process.
Okay. Did anyone have any other final comments about this case? Spoke sites, Ashley or David, Taupo?
I think if I managed him this time round, because this is a number of years ago, I would have gone with pregabalin, definitely, for the benefits for pain and for mood and ease of use. I would have also pushed his methadone. There was so much room to go up on that. But there was the balance of him getting more sleepy, which he certainly seemed quite sensitive to medications. And we also have ketamine up our sleeve, which we can use orally in the community if we need to. And so we'd be always very happy to discuss that. That usually does require admission in our unit to get it settled and started and then converted to the oral version.
David?
Ketamine is still not yet available to GPs for prescription. We're pushing it through Pharmac and they have okayed it, but it hasn't been rubber stamped yet, so it's still not available to be paid for by the state. If GPs prescribe it, we can buy the syringes, pre-filled syringes, for about $100 each, which of course we have to pass on to the family. Just be aware of that.
Tom?
Just to be aware as well that ketamine orally in the liquid form tastes awful. And we have a compounding pharmacy that we've used via Auckland to produce lozenges, which again, we certainly haven't used outside of the more metropolitan area in Hamilton, but we've used with good effect within the metropolitan area. So there's always a first opportunity, but that I think is a useful thing to know.
Tom, I've just got one last question. Did you see any evidence of the couple, the patient, having time to not only be depressed but express some of how he felt, what he was missing and would be missing with his wife or with you or with any other people, or did it kind of go underground a bit, just a general interest really, because there was enough other stuff to be dealing with pain, etc.?
He was a lovely guy who was obviously feeling a bit cheated, I think.
Yeah, sure.
I saw him as a home visit, and subsequently, in the next number of days, we managed to negotiate bringing him into the unit. And I feel that the team in the unit did a lot more in that area, and Debbie certainly was involved in the unit. And if you recall, Debbie, you might remember some of the conversations that were had. I seem to remember when I unpacked things here, it was really around his anxieties of managing symptoms, dying in pain, and the frustrations of getting the house to how he wanted it and not being able to enjoy it.
Yeah, thanks.
I think there were a couple of comments from me. One thing that we've not discussed at all, but which perhaps we tend to forget, is around sexuality and the very real, there's a physical reminder that aspect of this person's life has really changed dramatically. I think we don't feel comfortable with it often, so we don't talk about it. But sometimes an explicit discussion and acknowledging that's going to be a little bit awkward, but opening that opportunity for people. They may not want to discuss it, and that's fine, but we shouldn't ignore it. And I think the very real illustration in this case of the fact that pain is so multifactorial that we can't separate it into the physical and the psychological. This is a whole person, and the approach that works best is a whole person approach. Each aspect of that, so the medication aspect is important, as is the discussions with his wife, the planning for the future, the acknowledgement of grief. We can't do it well unless we do all of it, and ignoring any aspect of it removes the opportunity to deal with it adequately. So I think it was all done, and that's what worked. I don't think we can say that it was one thing that made the difference. It was the fact that we didn't do one thing, we did lots of things.
Great. Thanks very much, Tom, for that case. Very interesting, and thanks everyone for your participation in both the cases with questions and discussion and recommendations. So just to wrap up today, we will be, well, we don't really need to provide the recommendations. Usually we would provide the recommendations back to the case presenters so they have something to go away with. But just a reminder, our next TeleEcho clinic will be on the 21st of February, same day, Thursday, same time. If anyone from the spoke sites would like to present a case, we'd really welcome that. Just contact Andrea and she can send out the case template. It doesn't have to be really complicated and it doesn't have to be really long, just something that you found challenging that would be good to discuss and maybe get some answers for yourself from the people on the spokes and from the specialist hub. And also just to share the invite to these meetings with your colleagues. We're really keen to get more people engaged with our echos. We will be focusing on that a bit as well, particularly getting out to GP practices and inviting them as well. So thank you very much again, and hopefully we'll see you back in February, and have a great day. And I'll see you guys in Taupo next week.
Yeah, we'll provide the carrot cake.
Oh, good.
Oh, I'm coming too.